Hello, good evening, and welcome to 30th session of Anatomy of Abdomen. Before that, that's our disclaimer that this is for medical training purpose only, right? And all the images they are suitable for audience of not suitable for audience of all ages. It is for mature audience. All right. So let's start with our today's session, and this is rectum and anal canal. Now, this topic, it has got significant clinical significance, right? So we'll be talking about majority of the things which are actually related to clinicals. Plus, there are some very specific things. So for that, we'll be drawing few images or the sketches, and which will clarify all the doubts, right? And at the end of the session, we'll talk about tomorrow, because tomorrow's topic, that would be like all those plexuses and everything. It would be a super marathon topic. So about that we'll talk later, right? Okay. So so let's start. Sorry. So let's start with our today's session. See, when we talk about rectum and anal canal, very simply speaking, they are the last and final part of digestive system. Correct? They're the last and the final part of digestive system. So crudely speaking, they'll be for the storage and excretion of stool, right? And that's the process which is called as the defecation, elimination of stool. That process is called as the defecation. Plus, the way entire colon is doing the job of absorption of water, absorption of electrolytes, so does rectum too, right? So that is like similar to colon, right? There would be absorption of water and electrolytes. But still, there'll be few more other things also in this. So that's what we will be talking about. Here is the simplified diagram, and that's what showing us the situation of rectum, right? This is in continuation with sigmoid colon. Yes, that would come. Hemorrhoids, external, internal, yeah, that would come because it is related with portal hypertension. But it's not so that we'll be simply distinguishing between that, okay, these are the external hemorrhoids, these are the internal hemorrhoids. No, we'll actually understand the complete pathway. Why it happens that in portal hypertension, there it leads to those hemorrhoids. So for that, we'll be understanding the blood supply, that is the arterial and the venous supply in proper depth, because then you'll be able to understand the entire circuit, that why that pressure gets transmitted over there, and it is actually very interesting, right? So definitely. All right, so this is the sigmoid colon, right? And that sigmoid colon, which would be continuing with the rectum, right? At the level of, say, S3. That's the sacrum, right, on the back side. And all the way from S3 to S5 plus that coccyx, right? All is on the posterior surface of the rectum. Interesting is this, anococcygeal raphe. Between anus and coccyx, right? There is a raphe. This is about 2 to 3 centimeters, right? Posteriorly situated. And this is just for the support. That is what over there it is. But see, there is a dilated portion. This dilated portion is called as the ampulla. It is called as the ampulla, right? And you can appreciate that there is an angle. There is an angle. The angle which is called as the anorectal angle, angle between the long axis of anus, anal canal, and the long axis of rectum, right? This angle. So that angle, which is because of that pull of the puborectalis, so that's what we'll understand and we'll see as we proceed. But just understand this ampulla, it is the dilated portion, right? It is a dilated portion. Rest of the structures now we are quite familiar. Say this is prostate, that is the perineal membrane, perineal body, urethra, right? And then rectovesical pouch, very comfortable, and that's the urinary bladder, coccyx, and anal canal, right? So all good. Here it is. Now see, these are the some important curves which we need to understand in case of rectum. The first one, that is where we are watching it. Say, these are the two anteroposterior curves. Anteroposterior. So because they are anteroposterior curves, so it means that we are watching it from the side. Right? We are watching it from the side. That means this one, this side is anterior and this one is posterior, right? On the back side there would be sacrum, true? So that's the sacral curve, this curve, right? That curve, it's a sacral curve, so it follows sacrum, right? It obviously it would follow sacrum because there is no other structure behind it, it is just resting on it. And then this second one, which is called as the perineal flexure, right? This is bent posteriorly, right? It is bent posteriorly. That is what is forming that anorectal angle. Actually, it is rectus, right? When it is straight, that is the rectus. We say rectus abdominis, right? It is rectus, which means straight. All right. So that's about the anteroposterior. These are the two curves. One is the sacral and second is the perineal flexure. These are the two flexures or the curves. Now there are three more curves. Now these three curves, these are the lateral curves, right? So three lateral curves. So when we are watching lateral curves, that means we are watching it from the front, correct? So we are watching it from the front. This is our frontal view. Then and then we'll be able to see what is happening on both the sides, right? So this side, this time, this is right side, this is left side. So first curve is this. This is the first curve, right? Which is the upper right curve. Then comes this one. This is which is on the left hand side. So that is called as the middle left curve. And then the lower right curve, right? Lower right curve. That's how it is formed, right? So these are the major curves. Now about the peritoneal reflection. This is very specific, that how the peritoneum is actually associated with it. So for that we need to divide it into three parts. See the first part, this is the upper 1/3. So if you say that this is like a tube, so then from the top portion, right, it is taking the lateral surface. So all the way from lateral side, posterior side, and the lateral side. So that's how it covers. So sorry, lateral side, anterior side, and again the lateral side. So let's clear that out. This is anterior and this one is posterior. Right, now it would be good. So from the lateral side goes anteriorly and again laterally. So that's what it occurs in upper one third. Right. So that is one. When it goes down, that is the middle one third. In middle one third, it is only on the anterior. See, now over here on the lateral side, it is not there, right? So this rectovesical pouch, right, or the rectovesical fold, that is only now over here on the anterior aspect, and that's it. It gets terminated. So nothing on the lower one third. So in lower one third, and remember lower one third, what do you get over there? That is our ampulla, right? So there is no peritoneum, no peritoneum. So these are some important keywords which we try, right? We have already talked about this, that in case of, say, male, this is rectovesical pouch, correct? And in case of female, that would be rectouterine. That's right, right? Rectouterine. Yeah, pouch. Okay. Then, now about those viscerals, right? About those visceral relations. Now these visceral relations, they will change in male or female, right? So let's talk about the anterior portion first. In case of male and in case of female. So upper two-third, that would be closely associated with what we saw, rectovesical pouch, right? Very simple, right? Rectovesical pouch. What about female? It would be rectouterine pouch, right? Rectouterine pouch. Something is common between both of them, and that is the sigmoid colon. So sigmoid colon is what we'll watch in both the cases. So that is anteriorly. What about the lower one third? Lower one third, that is where the urinary bladder would come, right? So over here in case of male, this would be like a urinary bladder. Remember in case of female, right, what was happening, right? The bladder was over there, but the uterus was on its head, and then the rectum was over here, right? So that's why this bladder in case of female is not coming into picture into the anterior part. So over here, instead of this, it would be the lower part of vagina. True, right? Lower part of vagina. That is what would come in the lower one third. Right? And when we say urinary bladder, that would be the base of urinary bladder, correct? Now we know that in case of male, the posterior surface, right? That's the urinary bladder. The posterior surface is associated with what? Everything, right? Those vas deferens, then those vas deferens, they were telling hello to those seminal vesicle, then they were doing the joint operation to make that ejaculatory duct. They were entering into the prostate, right? And then into the urethra. So all those structures, they will be now, they'll be like dead in front of the rectum. True? So we have got the seminal vesicle, right? Then vas deferens, ureters, because all these are posteriorly situated. True? So that's how These are the visceral relation. What about posterior? Posterior part is, it has to be same for both male as well as female, right? Because it is almost bony. So we just saw S2, S3, S4 sacrum, right? Plus coccyx. In fact, it has to be S2 or S3, right? It will go all the way up to S5. Let me write it again a bit properly. So S2, which is questionable, sometimes there is a variation, but otherwise S3 to S5 is definite in the coccyx. So that's how it is posterior range. Then we saw one more thing, and that was that anococcygeal ligament, right? What we saw, that at the end of the coccyx, so anococcygeal ligament, then all those structures which we have already learned, piriformis, coccygeus, levatorinae, right? All of them which are forming the pelvic floor. So all of them will come into picture. So piriformis, right, levatorinae, etc. Now comes one important thing. We have already talked about it, that there is sympathetic ganglia, right? We talked about that. It is like that necklace, right? That beaded necklace from both the sides, that sympathetic ganglia, right? That sympathetic chain, it is getting formed. Now over here, as it goes down, it lands onto the finally one ganglion, right? So no doubt, sympathetic chain, that is quite logical, right? Sympathetic chain, but plus we'll write ganglion impar. Impar. Now this impar means what? Impar. The meaning of impar is something which is odd. Something which is odd. Now it makes sense. It makes sense, right? Because everything is impaired. Now this is the only ganglia which is unpaired, right? Which is single. It is unpaired. So this is only unpaired autonomic ganglia in the entire body, right? And what it really does, it marks the end of both sympathetic chain. So that's the ganglion impar, right? The only unpaired autonomic ganglia, right? So that is what is called as the impar. So this is different than others, so it is a bit odd, or you can say that because it is just one, so it is odd number, right? So that's how we remember. Okay, then antirami of S3, S4, S5 plus coccygeus 1, all of them, they will be over there, and plus there would be pelvic splanchnic nerves. These nerves will be coming today into the supply also, right? How they will be supplying rectum and anal canal, and how they will be playing a crucial role into many of the functions. Tomorrow when we'll be discussing the entire plexus, at that point some things would be very clean, right? That why they are over there, how they really form all the plexuses all the way from the top till this point of time, right? Finally, plus lymph nodes, fat, etc., right? That is all there. So that's how it comes. Here is all the structures what we talked about. First we see this ganglion impars, right? See, here it is, right? Here it is, right? That's the sympathetic chain. So both the sides, they terminate at this point. Here it is levatorinae, coccygeus, piriformis. These are the muscles which we are talking about, right? And then the transverse ridge, medial limb of pelvic mesocolon, right? And Say this is median sacral artery, right? Just to recollect, median sacral artery. Median sacral artery is that artery which is branch of aorta, correct? And it is unpaired, right? It is unpaired. And this artery will be playing a role into the arterial supply, right? Because this is emerging from back of the aorta, correct? And that supplies posterior wall of, in fact, anorectal junction. So, no doubt, right now we'll not be worrying much about it. But yes, when it will come to arterial supply, at that point we'll be talking about it. That how this is the rectum and that's the anal canal, right? And how it supplies only the posterior wall of anorectal junction. All right. Now let's talk about some very interesting things. These are the mucosal folds. Now we know about mucosal folds quite well. One important thing which we know is that there can be two types of mucosal folds. One which are temporary, second which are permanent. Temporary means the moment that organ is distended, they will be obliterated. We won't be able to see those folds, right? Permanent means whatever happens, whatever the distension is there, we should be able to see that. So these mucosal folds, and yes, we have to see them on empty rectum, because as we said that if the rectum is distended, then all those temporary folds, they'll go away, right? So this is divided into two parts. One longitudinal, right? One which is longitudinal, and second obviously which is transverse, right? One which is transverse. Now these longitudinals, they are temporary, or you can say they are transient. It means they will go away with distension, right? So when the organ would be distended, they would go away. Technically they will be obliterated, right? Practically understanding, that means they'll just go away. And this is what is seen in the lower part of empty rectum, right? So seen in lower part of rectum, right? Of rectum. Obviously empty rectum, because if the rectum is full, so then these will be obliterated. Regarding the transverse, right? Regarding these transverse, they are also called as the horizontal, right? It makes sense, right? Horizontal folds. And they are also called as the Houston's valves, right? Houston's valves. So many names, right? It is transverse, so they are also called as the plica transversalis, right? Transversalis. Plica means folds, right? There means plica means folds. So those folds, so these are the folds which are transversely situated. So they are plica transversalis, and yes, they are permanent, right? They are permanent. This means with any distension, they'll remain there, right? They are present even with distension. So these are the mucosal folds, how those mucosal folds, they are present. See. So here is, like, we'll be talking about those transverse mucosal folds. Now, because they are so specific, that's why we'll be watching it in so much of detail. This is the first transverse fold, right? Because see, they are permanent, so that's why they are giving all this appearance, right? So this is the first which is obviously on the right side. This is right side, this is left side, correct? That is right and left. So that one is the first transverse fold. About 4 to 5 inches from anal canal. That's the level. Then second one, this second one is appearing at on the left side, right? So this is on the left side. That's the second one, right? About 3 inches. All calculations from anal canal. Then this one is the third one. Again, it is on the right side. So one right, left, right, that's how they are going, right? So this is like on the right side, And what we are watching over here is a very important landmark, and that is ampulla. So we would say that this third transverse fold, right, which is the biggest, visually also we can figure out, right, this is the largest, not only largest, but it is just above ampulla. So that's why if you forget everything, it's okay, but should not forget this part, that it is the third transverse fold which is on the right side. It is the largest and it is just above rectal ampulla. That would be the important thing. Now why so? What other importance it is? Now that is what would actually make you very happy. So I'm drawing a line, right? I'm drawing a line, right? Making it a bit thick. Because this is the line, upper, right, above this line. That is what is developed by hindgut. Hindgut. Now in hindgut, which is the artery? You know it very well that it is inferior mesenteric artery. Right? The entire mystery that is lying over here, because this above portion is developed from hindgut. So that's why it is inferior mesenteric artery. That would be the playing major role. This lower one, right, the under this line, that is from cloaca. So it means over here the pelvic arteries, they will be coming into picture. Right? We'll see it in more detail, but that's how it happens. And yes, that's the ampulla. That is where there is maximum dilatation. Right? So that is all easy. Then this fourth one is a bit inconsistent, but as we said, right, left, right, so this has to be left, right? So this is the fourth one, correct? That's the fourth, and it is about 1 inch from the anal canal, 1 inch, and sometimes it is present, sometimes not, so we'll just put a question mark, right? That means it is inconsistent. So that's how all these folds, they are arranged, and the lumen would be something like this. So that's the game of this entire transverse mucosal folds. So when we talk about functional part, right? Talk about the functional part of rectum. So we divide, as we said, the upper part, and the lower part. And who was dividing it? Well, it was divided by that third fold, right? Third fold. So this upper part, this one, right? That would be covered by peritoneum, right? It would be covered by peritoneum. Yes, it has to be, no? Because oh, it is from hindgut. So it develops from hindgut. So that's where peritoneum would be there. Now over here, the lower part, that is developing from cloaca. So there is no question of any peritoneum. So over here, we won't be finding any peritoneum. So it's not there. That's what we talked about, that it is the third transverse fold who is handling this demarcation. And yes, this is a right-sided fold, right? And you are right. Now we understand the arterial supply, and we'll spend few good minutes on this arterial supply. Right? First, we'll understand arterial supply. Then we'll understand the venous supply. Then we'll understand the plexus. Then we'll talk about the porta-cable shunt. Then we'll see that what would happen in case of portal hypertension. And then we'll draw the entire circuit together so that we understand crystal clear that from where the blood is going and from where the blood is coming. Right? Okay. Regarding the arterial supply, pretty easy. The names are at least easy. Right? This is superior rectal artery, middle rectal artery, and the inferior rectal artery. Now it is not so that the names are given like superior, middle, inferior. So that's why, okay, the rectum divided into three parts and superior, middle, inferior. No, actually it would look like that, but no, they don't do it. And surprisingly, this inferior rectal artery, it is going all the way to the anal sphincter and it is supplying the anal canal, right? But still, we name it like inferior rectal. Okay, from where they come? Superior rectal artery, at least it is above, right? So it is from inferior mesenteric artery. That's very good, right? So this makes sense. In fact, inferior mesenteric artery is like its continuation itself is superior rectal artery, right? And this would be the major supply. This would be the major supply of rectum, right? We are right now talking only about rectum. So that is quite okay. For the middle rectal, now see, this is from internal iliac artery. It has got anterior division, and this is a branch of that middle rectum, right? And this would be supplying only the superficial coat of lower rectum, right? So only superficial coat of lower rectum. What about inferior rectal artery? This inferior rectal artery, see, there is one branch of anterior division of internal iliac artery, which is called as the internal pudendal artery. This internal pudendal, right? Internal pudendal. This is as such very important artery as it is supplying so many pelvic organs. And the branch of it is inferior rectal artery, right? And this would be supplying anorectal junction, right? Anal sphincter, right? That would be supplied. Now see, I have drawn these two things into different color because this is finally it is going towards IVC, correct? Internal, I'm sorry, IVC. It is going towards, it is going towards, it is from aorta, right? That terminal portion. And over here, there were three major arteries from aorta, that was the celiac trunk, superior mesenteric artery, and this one, the inferior mesenteric artery. right? So that's how they are formed. But it has to do something with foregut, midgut, hindgut. So, right, just remember this is the inferior mesenteric artery, and that is the hindgut. That is the hindgut. Okay. Now let's see slightly more in detail. What I'm about to draw is, this would be just an understanding, basic understanding of this structure where we are adding now the veins, right? Still, we are not adding one important artery and one important vein. I'll just tell the name, that is median sacral, because median sacral is very innocent. Median sacral artery would come, it will supply small area, and then it will go back into the median sacral vein. Bus done. That's it. So we'll include it after this, but first you have a complete picture, right? So I'm writing in short: superior rectal artery, middle rectal artery, and inferior rectal artery, right? Now see, very interestingly, this superior rectal artery, this is coming from where? This is coming from inferior mesenteric artery. Now, inferior mesenteric arteries continuation is, right? It is a continuation, and that is superior rectal artery. This means this has to be unpaired, because inferior mesenteric artery is only one, right? Now, then the aorta goes down, and then that aorta divides into common iliac, then it divides into external iliac and internal iliac, right? And then there is anterior and posterior division, and from anterior there goes this middle rectal artery. One another branch, and we'll write it like internal pudendal artery, and then it gives this inferior rectal artery, right? So our prime focus right now is this, this, this. Fair enough. Now let's change the color. Superior rectal, right? There would be formation of those plexuses, and then there will be internal plexus and external plexus. They are called as the venous plexus, also called as hemorrhoidal plexus, all okay. But this superior rectal artery, first thing is it would divide into two parts, because it is a lone artery. So it has to divide, it divides, and then it supplies the rectum, right? So it is one artery coming from the top divides, and then it goes into the rectum. Regarding this and this, they are paired, right? Middle rectal and inferior rectal, because from both the sides they are formed and they are going towards the rectum. Everything said and done, right? Finally, there. So just consider, in between there is all rectal tissues, and then starts the formation of veins. So here is superior rectal vein, again the middle rectal vein, and the inferior rectal vein, right? This superior rectal vein would drain into inferior mesenteric vein, because hindgut. And this inferior mesenteric vein, right, as it goes up, we know that it will be joining that splenic vein, correct? And then splenic vein would join with that superior mesenteric vein. It would form that portal vein, and then they will be entering into the liver along with, say, hepatic artery and bile duct, and that is what will form that portal triad, right? So this inframesenteric, right, I'll just write it over here. It will drain itself into splenic vein, and then this will go into the portal vein, and it goes. About the middle rectal and inferior rectal, again the same style. Inferior rectal, that would be landing into the pudendal vein, right? This pudendal vein will be draining into internal iliac vein. This middle rectal, right, that would drain directly into internal iliac vein, and then it would go into the IVC. So see, we have now two systems with us, portal system and the cable system, right? So it means this area, this area is is now a junction between portal and the cable system, right? So this is porto cable anastomosis. But where is the anastomosis? Anastomosis means that they should join, right? Here, so we have not yet joined anyone, right? So hang on. This much is clear. Now we'll be adding some plexuses into it. So that is where those plexuses will be playing a major role. So at least we understand this much, that in case if there is any rise in the pressure at the portal vein, right, anything, because it is going into the liver, right, if there is cirrhosis, right, anything goes wrong to the liver, anything happens, and then there is increased pressure into the portal vein, that pressure would backfire. That pressure would come down to inframesenteric vein. That pressure would come down to the superior rectal vein, right? That means if there is some weak area over here, that would start bleeding because of that back pressure. True? So that's what we'll watch. Yes, good evening. That's just a figure from the book, and I'll highlight some areas. Say what we highlight. See this one: superior rectal vein, middle rectal vein, and inferior rectal vein, right? And yes, this inferior rectal is draining into internal pudendal. This is into internal iliac, that is the anterior trunk, and then finally common iliac to inferior vena cava, and that's what leads to this portal cable anastomosis, because this superior one, right, is going to that superior rectal vein, to inferior mesenteric, to splenic, to portal, and that's how it goes. At this point, we would add one extra thing, and that is the median sacral artery. And this median sacral artery is from aorta, correct? That's from aorta. Similarly, there would be median sacral vein, and that will go into the vena cava. Right? So artery and vein, and that will go back to vena cava. This would be supplying, as we said, the anal canal, right? Or the posterior wall of that anorectal junction. So that's how this entire picture would go, right? All crystal clear, right? Now in this, we are adding just few points, because then we'll straight away be adding it into the form of plexus. One. See, superior rectal artery, right? It is superior rectal artery. As we said, this is a major artery. This means if it is a major artery, it would be carrying lots of blood, right? It means if anything goes wrong to it, things would bleed profusely. There would be heavy bleeding, right? Just keep this thing in mind. Where it goes, branches, because it will be divided into two parts, right? This is unpaired. There is only one. There is nothing like right or left superior rectal, because it is emerging as a direct continuation of, just remember, inferior mesenteric arteries continuation, right? It is the direct continuation. So this thing, all these branches, right? It would branch and they will pierce to supply all the muscular coats, right? So it pierces the muscular coat and it wants to give good intention. It wants to give oxygen with good intention, right? So that's over there. That is the superior rectal. Regarding others, they are fine. One was superior rectal, second is that middle rectal. Now, middle rectal actually is not a major supply, right? It will give only to the superficial coats of lower rectum. So only superficial coats, right? Only superficial coats of rectum. So if you really see the superior rectal and middle rectal, they have finished entire thing. So what about that inferior rectal, right? That inferior rectal, this one. See, inferior rectal would say, as such, see this level. Yeah, I'm talking about this point. This point. Inferior rectal is as such supplying anorectal junction, right? It is supplying anal canal and anorectal junction. So that is inferior rectal artery. But here it is forming that anastomosis. Now see, the things have started developing. It is doing anastomosis. It is doing anastomosis at anorectal junction, and with whom? With middle rectal artery, right? So middle rectal arteries, when they are coming from the top, they are coming from the top. So that's where middle rectal is coming from the top, and this inferior rectal artery, they are meeting over here, and that is anastomosis. So this is the first anastomosis which we saw. Rest is all good, right? Say middle rectal, this superior rectal, right? See over here. Now watch for this. It is coming down. That's the superior rectal. Just let me remove this. This superior rectal, and it is dividing into two parts. So even there also, right, it is supplying and it is creating anastomosis. So it means now over here there is anastomosis between, say, middle rectal, superior rectal, inferior rectal, right? All are anastomosing over here. That's right. That's right. Right? So, but major contribution is by superior rectal. Major is by superior rectal. This middle rectal is just giving these superficial coat. So it is, its contribution is as such very less. The major contribution is this superior one, right? So can we really say that it is like superior rectal and inferior rectal, that anastomosis is more important? Because see, in any case, middle rectal, they are just superficial. Okay, all right, but this should not make much of the difference. Arteries, na, finally, to all the arteries, they are coming from what? The great father is aorta, right? So that's okay. Means if someone is going via, is coming via, say, a common iliac, right, internal iliac, or someone is coming directly, so it won't be making much of the difference. Basically, to everyone is part and parcel of the aorta, right? That's okay. Someone is continuation of inferior mesenteric, and someone is getting branch and then coming, right, as we discussed about it. So in arterial system, there is not much of the complication. Things are good. But when it comes to vein, to understand that vein part, we need to see one extra thing, and that is when we say about the venous drainage, right? This time we'll not understand venous drainage like, okay, these are the veins which will do this. No. Let's understand it in two parts. First, the plexuses, right? Plexuses, they are the groups where all the veins, they meet and they create that picnic area. This is divided into three parts. There are three plexuses, three major plexuses. There are so many names, right? But right now, they are venous plexus, right? They are venous plexus. So we'll just write external, internal, right? External, internal, and one which is perimuscular. Perimuscular. Now, what this perimuscular is? Very crudely, if we draw that this is the rectum, that means rectum would be having the muscular wall, correct? Muscular wall, it has to be. So this is surrounding this, the plexus which is formed, it is called as the perimuscular. Perimuscular. All are venous plexus, venous plexus, venous plexus, right? Deliberately, I'm not writing everything. All are venous plexuses. But remember, this is external to muscular coat. External to muscular coat of rectum. Fine. Now these are external and internal. So it means where exactly would they be located? Now interestingly, say it is this internal venous plexus, right? Internal venous plexus, they will be formed, say, inside mucosa, submucosa, right? And the perianal tissue. That's where this plexuses would be formed. It means there is, so what about this external? Well, external, truly speaking, why to write more? Same, right? So then what's the difference? Now this is becoming confusing, right? And to add to this, let's add some more confusion. And when we say that this perimuscular venous plexus is again divided into superior, middle, and inferior. To simplify it, we draw a diagram in our own way, right? No doubt it would be very crude, but it will suffice the purpose. So here is the rectum, right? And that's the anal canal. Artery part we are drawing separately, but then it has to be superimposed on it. Fine. So because it is easy, so that's why I'm drawing it separately. Aorta, that's the aorta. From aorta comes the inferior mesenteric artery. From inferior mesenteric artery, that continues as superior. Okay, I'll keep on writing. This is inferior mesenteric artery, right? Then this is superior rectal artery. Superior rectal artery would be dividing into two. So that's the rectum, right? And that's the anal canal, right? So superior rectal, that would be dividing. And this aorta would divide it into two parts, right? Common iliac, that would divide into external and internal iliac, right? Internal iliac. And then from there would be the middle rectal and inferior rectal, and this is internal pudendal, right? So that's how things would go. True, right? Middle rectal, and then there would be internal pudendal, and then it would go like this. So this is inferior rectal and middle rectal. Once the blood reaches over here, it will be entering into the muscular coats, right? It will be entering into the muscular coats, and there, after those capillaries, there is formation of these plexus, right? There is formation of these plexuses. So the blood has come, and now they have formed the plexuses. Now these plexuses over here, this one and this one, right? They both are into the mucosa. So this is anal canal. So obviously we'll just call this as external and this as internal. Right? That's pretty easy. Internal venous plexus, right? Internal venous plexus, external venous plexus. Now see what really happens. This internal venous plexus, right? That would be draining into superior rectal vein, and that superior rectal vein all the way into the inferior mesenteric vein. That is what would be joining the splenic one over here. Superior mesenteric vein would join, and then that's the portal vein, and that's our liver, right? So that's how it goes. So here is, we would highlight superior rectal vein, and see it is handling internal venous plexus, right? What would happen for others? Now there is inferior vena cava, right? Inferior vena cava is formed by common iliac vein from both the sides. This common iliac vein is divided into external iliac and internal iliac vein. From this internal iliac, there goes, right, in that drains that middle rectal, right? Middle rectal. Then from this external, there goes again into it, right? Same thing on the opposite side, right? Over here and over here. So what we really watch is this area. It is this area which is actually where both the portal system and the cable system are meeting, right? That's porta, cable, anastomosis. Fine, because this is vena cava and this is portal vein. They both are separate. And to make it still bit easier, from liver there comes the hepatic veins, and those hepatic veins, they will be draining into vena cava, and then vena cava will go all the way to heart and then the entire circulation. You got this idea? Because this is that image which will give you complete understanding, because now it is much easy. Once you know this circuit, simply increase pressure over here. That increased pressure would all the way backfire onto this internal venous plexus, and that's why they are also called as the hemorrhoid plexus. Hemorrhoids, hemorrhoidal or hemorrhoid plexus. Hemorrhoids is another name of piles, right? And then we'll see the difference between internal and external, which is painful, which is bleeding more, etc. But that's how the whole structure and everything is arranged. All right. From this point onwards, things are now pretty easy, right? Because say now in the venous drainage, in fact, we have drawn everything, so we know that superior rectal vein, that superior rectal vein, which will be draining into inferior mesenteric vein all the way, it will go into the portal vein. But this superior rectal vein, it is handling in interior venous plexus. But that's the important part, right? So all those tributaries, they are draining into superior rectal vein, right? And yes, they do pierce muscular coat, right? Muscular coat, fine. Now for the middle rectal vein, there'll be tributaries from rectum and ampulla, right? So that's the lower portion. So lower rectum and the ampulla. That's the point from where they will drain, right? They will be going into middle rectal vein, and then this middle rectal vein will finally go into the internal iliac vein. So that is done. We are not adding inferior rectal because inferior rectal is as such not playing part into the rectum, right? It is for the anal canal. So this is, if it is number 2, so then number 3 should be median sacral, right? It should be median sacral. This median sacral vein, that would be draining into, now again see median sacral vein, right? So that would be draining into left common iliac, right? Done. And this would be supplying anorectal junction, the posterior part. All veins and veins and veins, but there were arteries, right? So it is like if we understand this figure, right? So then efforts to learn veins will not go in vain, right? That's the lymphatic drainage. And as always, we divide it into two parts. Upper half, that will go into pararectal, right? So this is for upper half. It will go into pararectal, and from there it will go to those inferior mesenteric nodes. Same reason, hindgut, right? And the lower half, it will go all the way down, right? It will go into this, see, internal iliac, then it will go into those horizontal set of superficial inguinal nodes, right? So that will go, it will drain like this, and this will drain like that. So both are separate. Now supply. In case if there is any confusion, just let me know. I'll repeat the veins part because it is very much important to understand it. So there's nerve supply, and it is sympathetic and parasympathetic, right? And again, there would be joint operation by both of them. Sympathetic. For the formation of sympathetic, yesterday we were talking about those hypogastric plexus. So this sympathetic, superior hypogastric plexus, inferior hypogastric plexus, and one more thing, and that is lumbar splanchnic nerve, right? So all of them, they will be splanchnic nerve. So all of them, they are handling sympathetic. For the parasympathetic, there would be very standard pelvic splanchnic, right? Pelvic splanchnic nerve. We must have written its root value million times, S2, S3, S4, right? Pelvic splanchnic. But to add this, there is inferior hypogastric plexus. So that means this inferior hypogastric plexus, it is handling sympathetic as well as parasympathetic. Very true. It would be handling both, right? Sure, I'll explain, right? So let's just finish this nerve supply. So sympathetic, parasympathetic, right? Superior hypogastric, inferior, and that's for sympathetic, and the parasympathetic is this, right? There is no superior hypogastric into parasympathetic. This is one. Interestingly, the pain fibers, right? Pain is handled by both, right? So do remember that pain is handled by both. So when we say sympathetic, right? L1, L2, right? We said that pain would be handled by both, but this sympathetic would be doing what? Sympathetic would always constantly be working, constantly, because they are vasoconstrictor. They are vasoconstrictor, right? Then they would inhibit rectus muscles. It would say, no need to contract, right? Just relax. It would be motor to internal sphincter, right? Now we'll talk about these internal sphincter and external sphincter, but in nutshell, we know that there are two anal sphincters. One is internal anal sphincter and second is the external anal sphincter. This internal is I for I. It is involuntary. So that means this sphincter is under the control of autonomic nervous system, right? So this is involuntary. External is voluntary. So we'll look at it, its supply. But yes, this is carrying pain sensation. Yes, surely it will carry the pain sensation. Pain sensation would be carried by the parasympathetics also. So this is what it would do. Normally sympathetic is in action, right? So it is telling rectus muscles, you don't contract. And internal sphincter, motor. So when it is motor, that means it will contract that sphincter, right? So this sphincter, internal sphincter, will remain closed. About the parasympathetic, S2, S3, S4, right? And this parasympathetic, yes, this would be also carrying the pain. So let's write it down. But this is doing just the reverse of it, right? It would stimulate the rectal muscles. So rectus muscles would contract. When they would contract, it is necessary to tell that internal sphincter that now you relax, right? So this is internal sphincter relaxed. But how on earth this parasympathetic would know that when is the correct time? Right? That is where this parasympathetic would also handle the sensation of distension. Distension, right? So every morning, run to that washroom, right? Say thanks to S2, S3, S4. It is the parasympathetic, right? Which is sending the signal that, okay, that's the time to evacuate, right? And then parasympathetic would say, okay, sympathetic, now your work is over. Now let me handle. And then it, it really works. Now, all these mechanisms, they are going via, right? As we said that there is a common conduit, there is a common tube via which all the fibers are going, right? And that is through, you must have guessed it, inferior hypogastric plexus, correct? Now you know that it is the inferior hypogastric plexus which is handling parasympathetic as well as sympathetic, right? Because for sympathetic, things are coming via superior hypogastric plexus, right? It would put it into the tube of inferior hypogastric plexus. Inferior hypogastric plexus is already carrying those parasympathetic fibers, and then the entire tube goes and that enters into the rectum into the form of a nerve that is superior rectal nerve. So the nerve which looks so simple but actually it is carrying so much, right? So that's how it handles, right? Pain, sensation of distension, right? When to relax the muscles, when to close the sphincters, when to open the sphincters, all those things that is handled like this. Fine. Okay. About the discussion of that vein, right? I'll try to make it still easier. That's the rectum, that's the anal canal, right? And just take it for granted, blood has come. Blood has come all the way from aorta. Whether it is by inferior mesenteric artery and that is coming up, right? And then that superior rectal artery is dividing into two parts, right? Or this aorta all the way, right? It is going down, dividing, right, into common iliac, internal iliac, external iliac, and then this is internal iliac which is giving those branches, right? Middle rectal artery and inferior rectal artery. So in short, blood has come, right? So let's make some space now. So blood has come. It forms two plexuses, right? Because they will divide all these arteries. They have got habit, right? They will keep on dividing. They will pierce into those muscular coats, right? They will go into the mucosa and then finally, once again, they all join, right? That's what really happens, right? So this is the one artery, it divides, again it divides, again it divides, again it divides, and then they join, right? They join and they join, and this is what is called as the plexus, right? Plexus. Because that way they can reach to large amount of area. Now here is the artery, and when the blood goes, that's the vein. So this is simply, that's the anal canal, right? So obviously we'll call this thing as external and this is as internal plexus, right? And because now these plexuses, they are from the veins perspective, so they are the venous plexus. Simply speaking, this internal venous plexus, it drains into superior rectal vein. And this superior rectal vein would go into inferior mesenteric vein, and then rest of the journey you know it very well, right? It meets that splenic. Over here it is superior mesenteric vein, and that leads to that royal portal vein, right, which goes into the liver. This part was easy. About this, right, from here and here, they both will be going into internal iliac vein, directly or indirectly. They will go into internal iliac vein, and from there internal iliac to common iliac, and finally it would be going into inferior vena cava, right? Not in this direction, it will be up, right? This is just for the sake of simplicity, right? So we do have one, the portal system over here, and we do have a cable system, right? Vena cava cable system. So that means this would be our junction point. That's the junction point where they both are meeting, right? So that's how things really go. I think now it must be pretty clean. Okay. Now the supports of rectum. Whenever it comes to support, remember one thing, that means that organ has got chances of prolapsing, right? So if anything goes wrong to these supports, it can prolapse, it can come out. When it comes out, it's a very difficult situation, right? So first support, what could it really be? Levator ani, in other words, the pelvic floor. Pelvic floor itself is so strong, right? But it has to be strong, right, for the rectum. The second, what is called as, see, between that's the rectum, that's the ampulla, right? That's the ampulla. And on the back side, there is sacrum, right? There is sacrum. That's what is called as the fascia of Walder, right? It is called as the fascia of Walder. It is nothing but a condensed fascia, right? Between rectal ampulla, that's the ampulla, and the sacrum. So this is a condensed fascia. So if it is a condensed fascia, yes, it would try to keep it pulled, right? The third thing, on the lateral side, on each side, you got the lateral ligaments. And yes, all these ligaments, they are as such a sort of condensed fascia, right? Then there would be rectovesical fascia, right? That is what is forming the pouch also. So that is rectovesical fascia or fold. Perineal body, that is where all those 10 muscles are landing. That would also provide support, right? So this is perineal body that is supporting, right? And finally, the pelvic floor, right? In fact, pelvic floor to be wrote. So that's how they are, say, supported. This is what is called as the per rectal examination, right? PR or the per rectal examination. Now, per rectal examination, there has to be a purpose. One, say within lumen, right? What can be really seen? That is there any fecal impaction, right, which has led to impaction, which has led to severe constipation? Is there? Is there any foreign body? In Love Bailey, right, the textbook of surgery, there is one very interesting image, right? People put all sorts of things into this area, right? Someone put that a small piece of I think it was that salt and pepper container, right? And on that it was written from Love with Martha, right? So someone used that, right? So that's where the foreign body, they are there, and the bleeding piles. When the piles are bleeding or the hemorrhoids, so that is over there. So this is within lumen. In rectal wall, right? Then second, in rectal wall, is there any growth? Is there any growth? So then that can be examined. Or the other way around, is there any stricture? Right? It is just so narrowed. Is there any stricture? So that can really be assessed. Or nothing in lumen, nothing in rectal wall, outside the rectum. That is, right? So outside. So that is where the bladder, right? Is there any stone? So bladder or any stone, right, into the lower ureter, so that can be examined, that can be. So these are some of the basic things which can be, say, examined. And yesterday what we were discussing for benign prostatic hyperplasia, right, even that CA prostate, even that thing can be examined. So in case of females, the uterus, right, uterus enlargement, that can be examined, plus the uterine tubes. In other words, whatever the structures which are nearby, right, uterine tubes, they can be examined. Proctoscopy, right, also called as the sigmoidoscopy. Scopy means to watch, right, with the help of instrument. So that is where you'll use a device for watching the internal piles growth, especially into the lower rectum, right? So that is for growth or piles. What we were telling was prolapse of rectum, right? That's what we were telling, prolapse of rectum. Now, prolapse of rectum, it can again be divided into two parts. One, which is incomplete, right? Which is incomplete. And in incomplete, it is only the mucosa which prolapses, right? Not the entire structure, not the entire rectum. So incomplete means it is the mucosal prolapse. It is the mucosal prolapse, right? When we say complete, name itself is telling complete, right? That means everything. And this has got a very, very classical name. And this is what is called as the procidentia. Procidentia. Procidentia means complete rectal prolapse. Now, we saw all those supports, right? Any of those support, maybe laxity of pelvic floor. When the pelvic floor is weak, right, it can lead to such things. Now, all those things, they usually never occur when the person is young, it occurs at a late stage, right? That's the importance. Yes, Gauri, there can be variations. That's right. Normally, it is like, say, many times, I'm just deviating from the topic, but if you'll see any of the reference book to then say that in 7% of the cases, this vein is absent. In 15% of the cases, it drains into this, that, but commonly it is seen in that it goes into the left side. Variations, they are always there. Right? So this complete prolapse of rectum, that is, in simple words, it is because of the laxity of pelvic floor. Pelvic floor. So at times when I see that medicos suffering from any of such disease, right, that is a painful thing because this is all avoidable. Right? In when you are young, those exercises, they can really keep your body into very, very strong state. Moving on to the fourth point. This is sacral denervation, right? It is what is called as the sacral denervation. If it occurs, it leads to automatic rectum evacuation, right? This is bad situation, right? That is when those nerve plexuses, when they are ruptured or affected, so this is automatic rectum evacuation. But everything said and done, you will find that in your patient, if this thing happens, then bladder is more badly affected, right? Urinary bladder is severely affected. It is more affected as compared to rectum because it is fluid. So that would be giving way much faster, right? Then, like say CA rectum, carcinoma of rectum. This carcinoma of rectum, its secondaries or the metastasis, right? They can really spread very far. They can spread, and in this case, the surgery is painful. It is what is called as the en bloc removal. That means all the way from sigmoid colon to rectum to all the structures which are coming in the path, anal canal, right? All they are removed, and then the stoma is just kept over there for the evacuation. It is what is called as the en bloc surgery. The entire piece is completely removed. We'll spend some time on the discussion of this anorectal ring, right? That puborectalis, what it really does. Because if it is damaged, it would lead to rectal incontinence. Rectal incontinence. Now you know what is continence. Continence means holding up. Urinary continence means holding up the urine. Urinary incontinence means person is unable to hold the urine. That is especially when the intra-abdominal pressure rises, right? That urine is leaked. Same way this is rectal incontinence, right? That is due to damage of this anorectal ring. So this was about rectum, and now we move on to the next topic. This is anal canal, relatively small, right? But important. And so many things we have already talked about it. So that's the anal canal, and on both the sides, right, there is ischio anal fossa, right? There is ischioanal fossa on both the sides. In this, there were two sphincters. One was the inner sphincter, and another was the outer, internal and external, right? And this inner or the internal was involuntary, and this one is voluntary. Right? So this is just in brief. Now, when we talk about how exactly it is located, right? Two things we'll understand instantly for the relations, right? For the relations, the anal canal anteriorly, don't forget to mention perineal body, right? Because that is the most important anterior relation, perineal body, right? Then in case of male and female, there would be minor variation. In case of males, there would be membranous urethra and the bulb of penis, right? So there would be, say, bulb of penis. And in case of female, it would be the lower end of vagina. So that's the in the anterior relation. Posteriorly, it is same. Posteriorly, it would be that anococcygeal ligament, right? What we were drawing, that this is the coccyx, and then that was the anococcygeal ligament, right? Anococcygeal ligament. So that's what there it is, right? And on the lateral side, we have got that ischial fossa, what we talked about on lateral side, right? Both the sides, there is ischial fossa. Now that's where things are to be understood. This is interior of anal canal. Points to be seen in this, that it is divided into three parts, right? One, this is the upper part. This upper part, see over here, these are all mucosal folds, right? These are all mucosal folds. Those folds, right? They are going like that. Now those folds, they are called as the anal valve, right? These are all short transverse folds. And these folds, yeah, white line of Hilton is here, right? This would be called as, so we are coming to that. So these are the all the, these are called as the valves, right? These are called as the valves, anal valves. And these are all folds. They are called as anal column, right? 6 to 10, about 6 to 10 vertical columns, and at the base all of them, they would be reflected like this. So practically speaking, when they do it like this, right, like this, so they form a sort of line, right? A sort of line. This is called as the pectinate line. Pectinate line is formed by anal valves. It is formed by anal valves. Now the importance of this pectinate line is that the area which is above, it is endodermal in origin. So above one is endodermal and below it is ectodermal. So that's the importance of this pectinate line, right? So that is one. The second, the middle portion, right? This middle portion. So above it is, there are all those mucosal folds, but over here in the middle there are no anal columns. There are no anal columns, right? What we'll see over here is those dense venous plexus, right? Those dense venous plexus is there seen. And that's why this thing would look dark or the bluish, because all the venous plexus will be there. Here, what type of epithelium, right? It would be stratified, right? It would be stratified squamous epithelium. And over here, when outside, it would be keratinized, right? So here, there are no sweat glands. There are no sweat glands, right? And this is stratified keratinous. Now, one interesting thing is, right? If you have seen Discovery Channel or you are watching any of the wildlife, you must have seen that those animals, right? They keep on going on the backside of other animal and they keep on smelling, right? It is because of this area, because of this area, this area. As we said that these are like anal sinus, right? These are anal sinus. Sinus is this a space, right? It is a space. But these sinuses, they are having anal glands, right? Anal glands. And these anal glands, they actually secrete, right? They secrete. And those animals, right? Lower animals, they use that smell for attraction, right? So it is like lower animals, they use it for attraction. That smell is used for that, right? Finally, this is like white line of, it is called as the Hilton, white line of Hilton. This is a junction because this in between area, what is called as the pecten or the transitional zone, right? It is called as the pecten or the transitional zone. So we have got one area which is the upper area, second one is the pecten or the transitional zone, and the lower zone. This lower one, this is where the true skin is there, right? It is just the skin because it's now the final part, last part. And that is where there are sebaceous glands, right? There would be hair follicles, right? Hair follicles, etc. So that's how all these things, they are divided into, say, parts. Watching it further, in this we need to see two important things because this is like musculature of anal canal, right? And it would explain musculature of anal canal, and it would explain the concept of sphincter. But that's it. The sphincter is to be seen that how exactly it is arranged. And there are two sphincters, internal and external. The thing is that internal sphincter is relatively simple, right? Where it is? Here it is, the internal anal sphincter, right? That's the internal anal sphincter. There's one, right? That's the internal anal sphincter. And its fibers, they are going all the way up, right? All those circular fibers, right? Those circular fibers, because this is a section. So that's the internal anal sphincter. All the way up to the anal canal, except the final part. There comes the external anal sphincter. Now, this external anal sphincter has got the upper, middle, and the lower part. So, here is the upper, middle, and the lower part, right? This external anal sphincter is voluntary, right? And that's why this is going beyond internal anal sphincter. So even if the internal anal sphincter is open, this external one voluntary should open for the process of defecation. It is divided into these specific parts, right? Three parts, upper, middle, and lower, which you can also say it like that one part which is deep, right? So that is upper, right? That is deep. Then the middle one, we can also call it superficial, right? Because it is relative thing. So this would be superficial. So then what should we call really the lower part? Well, the lower part would be what is called as the subcutaneous, right? This is subcutaneous. That's subcutaneous. So that's the thing, right? And this is thrown into, say, fibroelastic septas. And see, these are the circular muscles and the longitudinal muscle, right? Longitudinal muscle. And that's what they comprise of this sphincter. Now to do this thing, watch for this puborectalis, right? Very silently, puborectalis. Just watch it that that's the location of puborectalis, because now we are about to talk about, say, puborectalis, right? Lower animals means all those into the wildlife, those dogs, cats, etc. So external anal sphincter, we divide it into three parts, right? Because every part is associated with something very specific. So this is uppermost, right? This is the uppermost part. This uppermost part, just one word would be sufficient, that is puborectalis, and we are about to talk about it, right? Then interior and posterior. What we really get. So this is external anal sphincter, so there will be superficial transverse perineum, right? Superficial transverse perineum. That is what is forming that perineal body, right? So this is upper. So from there, those fibers, they come. So this means when we talk about this middle fibers, right? Middle one, over here, there would be perineal body, perineal body. That is what we get, right? Anteriorly, obviously anteriorly, because see, this anal canal, that is the posterior most structure. Posterior to that, posterior to that, just one structure which is going with between anal canal and the coccyx, that is anococcygeal ligament, right? That's the only posterior thing. So it is this perineal body, right, which is in the middle, right? And this is superficial transverse perineum, deep transverse perineum, right? All of them, they were landing onto the perineal body. So that's over there, right? Again, even in upper part, it is the anococcygeal ligament, right? How about lower fibers? We only said that it is just very just subcutaneous, right? So there is submucosa, nothing more, right? So that's how this external anal sphincter is arranged. See, that's the puborectalis, right? That's the puborectalis. So in case of male, this puborectalis muscle, it is forming the uppermost fibers of external anal sphincter. That means this external anal sphincter is there, and its uppermost fibers, they are associated with puborectalis. Right? That is what really forms, it is what is called as the anorectal ring. It is acting as one piece, right? It is acting as one piece. This is puborectalis, right? That is what really happens in case of males. Now see in case of females, and just let me draw, right? In case if it is not clear, say for example, say this would be rectum, that is ampulla, and this is the anal canal, right? Over here, there would be pubic symphysis, right? So this puborectalis, right, from one side, it will go like this, and then like this. So this is puborectalis, right? And do you remember I said that it is forming an angle? So that's puborectalis. This would be pubic symphysis, right? And that's the anorectal angle. So it acts like a sling, right? It acts like a sling. So when it pulls, it is acting as a valve, right? This is the external anal sphincter. Now, because this puborectalis, this is under voluntary control, that's how it really goes. But say in case of female, the anorectal ring, this puborectalis is separate then from the external anal sphincter. It is separate, right? So when in case of female, they both are puborectalis and external anal sphincter, if they are separate, that means surgical division. If the surgery is done, right, and if it leads to damage, so then surgical, say, division or the cut may lead to rectal incontinence, right? Because the entire power is lost. So this is very crucial in case of, and that's why the process of parturition, giving birth, right, when there is so much of stretching, right, everything is so, all these things, they are so important. Okay, we are watching this thing again just for one reason, and that is, see, the junction, this junction, this one, this one, that is what is called as the conjoint longitudinal coat, right? This is this area, it is called as the conjoint longitudinal coat. How it is formed? Puborectalis plus long muscle coat of rectum, that's the combination, right? Say, what is its importance? It is between two sphincters. So this is external, this is internal, and in between what you are getting is this conjoint tendon, right? So it is puborectalis, what we saw, plus the longitudinal muscle coat of rectum, right? Longitudinal muscle coat of rectum. So that's how it is formed. Rest is all, if you see on both the sides there would be ischianal fossa, white line of Hilton, right? And all those fibro elastic septa, these septa, right? See here. This is what is called as the surgical space, right? These are the surgical space, worth understanding and pretty easy. First thing we pick up the easiest thing. On both sides of anal canal, this is ischioanal fossa. So that's what ischioanal fossa is. So if I really draw it like this, right? This is just the half part of it. So there would be another half, right? Say, right? Compare it with this. Compare it with this. Say if we are picking up only this much area, only this much area, right? See, compare it, right? We are picking only that much space. So let's take it like this, that the anal canal is here, right? And that is the ischioanal fossa. So this entire fossa, right? The fossa, which is here is the anal canal, right? That's the anal canal. Similarly, it would be like this on the opposite side, right? So this fossa is ischioanal fossa. Let's mark it as number 1. That is the ischioanal fossa on the each side of anal canal. That is easy. The second fossa is over here. This one. That is what is called as the perianal fossa. Now, perianal fossa is that if there is any infection over here, right? If there is any infection over here, this infection won't spread up. That is because of the presence of perianal fascia. There is fascia. This fascia, it will prevent the infection to go into the ischioanal space or the ischioanal fossa, right? It would prevent it. So this is first point. That is 1, and this one is second, right? Then all those septas, right? Fibroelastic septas, they are there. And white line of Hilton, all rest of the areas we talked about, right? This is like external anal sphincter, fused submucosas, and mucosal membrane, longitudinal and circular muscles of rectum. But this is one important thing, that from here this infection won't spread thanks to this perianal fascia. For the arterial supply, again, we'll be dividing into two parts like this, right? So above, right, above pectineal line, it would be superior rectal artery, which is continuation of inferior mesenteric artery, right? And below, that would be by inferior rectal artery. So here is now the inferior rectal artery. That's its purpose. That is, to be precise, inferior rectal artery, it supplies the anal canal below pectinate line, and that is its function. Okay. So moving on to the final part now. The venous drainage, right? We said that it is the internal rectal venous plexus. Now there is another name also. It is also called as the hemorrhoidal plexus. Hemorrhoidal, right? Hemorrhoids. Hemorrhoidal plexus. And it should be very easy now to understand that this is by it is drained into superior rectal vein, correct? Superior rectal vein, because that was the main one. And this internal rectal venous plexus, it also communicates with external venous plexus. It also communicates with external venous plexus. And this external venous plexus is draining to middle rectal and inferior rectal veins. So that's how this becomes a junction for portocaval anastomosis. Right? That's where they all meet. We have already talked about it, but still. This is slightly more in detail. That all these internal plexus, right? All those internal plexus, when they are formed, right? There are some major arteries and there are major veins and the secondary veins. So those piles, they usually develop, that is what is called as the position 11, 3 and 7. So 11 o'clock position, 3 o'clock position and the 7 o'clock position, these are the main sites where it can occur, and that's why these are like the potential sites, right? These are also called as the potential sites for the development for primary internal hemorrhoids. So they are given the name, right? This side is right, this side is left. So this is right anterior, that's right posterior, and this is left lateral, right? Fair enough. Any of those things other than that, they are all called as the secondaries, right? So these are main and they are the secondaries. The thing is, they bleed, these internal piles, they bleed profusely, heavily, profusely. Because who is feeding them? That superior rectal artery, right? It is feeding, and that's the major one. The external, right? External rectal venous plexus. So that is outside those muscular coat. So they communicate freely with all the plexuses. The next one is, so when we talk about anal veins, right? They are arranged around the anal margin, right? They are arranged around the anal margin, and that is around anal margin. And that's where the inferior rectal veins, they would come. So in that case, say any of the increased strain, right? Increased strain in the form of, say, constipation, right? In the form of constipation will put a load on that, and there would be rupture, right? These veins, there will be rupture of those anal veins, and that would lead to what is called as the external piles, right? These are called as the external piles or external hemorrhoids. In such cases, after examining, such patients are given stool softeners, right? So that there is no strain. That pectinate line is important even from the perspective of, say, lymphatic drainage, right? It is important from the perspective of lymphatic drainage. Above, they will be going for internal iliac, right? Internal iliac nodes, and below, this is the pectinate line, pectinate line, and below, they will be going for those superficial inguinal nodes, right? They will be going for superficial inguinal lymph nodes. Now, regarding the nerve supply, again, this is very specific, pretty easy. Same way, pectinate line will come into picture. Say pectinate line. The lower portion, this is somatic, voluntary. So it would be by inferior rectal nerve. Inferior rectal nerve. Same S2, S3, S4. So that is easy. The top portion that you already know, sympathetic, parasympathetic, right? Sympathetic, that is the inferior hypogastric plexus, in which that superior hypogastric plexus has fed some of the fibers, right? Parasympathetic, that is by pelvic splanchnic nerves, right? S2, S3, S4, right? And pain, who will carry the pain? Both. Both would carry the pain sensation, right? So that's how the nerve supply is. Pretty similar to that rectum. Things to know is now this, that what about the sphincters? Right? Those sphincters, they were special because we were telling that it is the external sphincter and the internal sphincter, and this internal sphincter is involuntary. Yes, so that's what we were telling, that if it is involuntary, so then there is sympathetic and parasympathetic, and it is always that sympathetic will keep on working, right? It is always on, so it will contract that sphincter, so nothing is leaked. And when it is the correct time, right, it will relax the internal sphincter, right? But what about external? External to is voluntary, no? Right? If it is voluntary, so it is controlled by, as we said, inferior rectal nerve, and add one more. This is very important. Its root value is S4. This is perineal branch of sacral 4. Perineal branch of sacral nerve. Right. So this is voluntary. All right. So this is just some comparison, right? Which we talked about, that in development, upper part is hindgut and this lower part is, say, endoderm, and this is ectoderm, this is endoderm. Lining is simple columnar stratified, simple columnar epithelium, this is stratified columnar. Then superior rectal main, this would be inferior rectal. Then it drains into portal vein, this drains into systemic veins, internal iliac lymph nodes, superficial inguinal lymph nodes. Nerve supply is autonomic, that is sympathetic, parasympathetic. Over here, inferior rectal, we already talked about it. Sensory to ischemia, distension and spasm. In distension, right over here, it is pain, touch, temperature and pressure, all the things which are related to skin. Right, types of piles, obviously they are deep, they are called as internal, and this one is external. Right, quite okay. I know session is quite lengthy, but can't help. See, the clinically, one, what is called as the internal piles, right? These internal piles. Now, some points are to be understood. They are called as the true piles. They are called as true piles, right? Over here, they will be bleeding heavily, right? The reason, right? They bleed heavily because who is supplying them, right? Bleed heavily. That is one. Second, they are painless. That's very important because all those pain fibers, right? They are near the skin. So they are below. And this would be internal piles will be because of those sac-like, so sac-like dilatations. Sac-like dilatations. Sac-like means they are called as the saculations, right? They are called as the saccular dilatation, sac-like dilatation of internal venous plexus, correct? Internal venous plexus. And this internal venous plexus is what is in continuation with all the way up to the portal system. True? 3, 7, and 11. These are the commonest location, right? And which vein would be involved? No doubt about it. Now you know it so well. It is the superior rectal vein which would be mainly involved, right? If you say these many points, right, and because you have understood everything, it would be very easy to remember and very easy to judge. Why should it really occur? What are the factors? If the factors are asked, now you know the whole circuit, right? You will say first thing, portal hypertension. Now see, portal hypertension, they are such topics that normally no one would like to touch it. But now you have understood it so effectively, the moment you say portal hypertension, immediately the examiner would love to ask you more about it. But because you now know the whole circuit, it would be a pleasure, right? You will be happily explaining everything. So this is one, the portal hypertension, the back pressure, right? Second, why they should occur? Because we talked about that there are no valves. There are no valves. In veins, there are valves, right? Varicose veins, they occur when those valves are disrupted. Otherwise, when the blood is going up, right? So there are valves. Those valves, they help and they prevent that backflow. But over here, there are no valves between what? Between superior rectal vein and the portal vein, right? No valves. So that means if any pressure is to be backfired, right, it will come straight away. Third important point. These veins, right, veins, they are compressed. They are compressed. Why should they compress? At the point when they are piercing the muscular cord, at the point of piercing of muscular cord. So it acts like a valve. So this is like a muscular cord, and that vein is over there, right? It is piercing like this. When these muscles they contract, so it will actually contract, so that it will lead to decrease in the caliber of this vein. So this is how the veins they are compressed. And then the loose connective tissue that is all over, right? Connective tissue. There is no one to protect these veins properly. So that is the commonest thing for, say, this true piles. So then what about the external piles or the external hemorrhoids? So should we call them false? Yes, absolutely. right? They are the false piles. Near the skin, so painful. So patient would be shouting, right? They are below pectinate line. Fair enough, right? They are below pectinate line. And say, is the bleeding profuse, right? Profuse, heavy bleeding? Not really. Not really. Because the supply is not that huge, right? So they won't bleed that profusely. Others are like, say, other conditions are like, say, fissure in ano. Fissure means nothing when the two cavities, right? When there is a crack, right? When there is a crack. So that crack is called as the fissure. When there is a rupture, right? That is called as the fissure. And this is very painful because it is superficial, right? That's where there are lots of nerve fibers. So it is very painful. Then comes the word fistula. Whenever the word fistula comes, right? Fistula in ano. When the fistula comes, that means two cavities, they are connected. Now these two cavities could be two cavities, two closed cavities, or it could be one open environment, right? Any of those things, they are called as the fistula. So that's why it is like an abnormal track, right? This track that is between two cavities or one cavity and other is exterior. So how it can really occur? Whenever there is any abscess, right? Pus formation, right? And it ruptures. So that can lead to formation of this abnormal track. And this is like, where can it really go? Say for example, that's the abscess, right? It is the anorectal abscess. Anorectal abscess, the collection. If it goes laterally, yes, we know this part, right? Because on the lateral side, there is ischioanal fossa, correct? Ischioanal fossa. Things have gone wrong into the anal canal, rectoanal abscess, so it goes into the ischioanal fossa. What if it goes medially, right? It will go into those anal sinuses, right? All those mucosal folds, right? Anal sinuses. Or if it goes up, it will travel up and it will go into the rectum. Or if it goes down, so then it will straight away be coming out, right? Exterior. So that's how it can actually spread at any of the location, right? So this was the rectum and anal canal, and that was our today's topic. Right? So I think it's almost 2 hours or more than that. Yeah, it's more than that. More than that. Tomorrow's topic is still super marathon. Today was marathon, so then tomorrow would be like a super marathon. Because so many plexuses, so many things to understand, right? But yes, we would take it. We would take it. So how about, say, meeting at 6 o'clock in the evening? Is it okay? 6 p.m. Is it okay? Because there won't be much logic in dividing into two parts. Some things are to be learned in a single shot. And yes, you are medicos, so need to develop develop that endurance to handle long lectures. Everything is in fair, very nice. And yeah, actually, it is like a war. Actually, because when you'll go for the final test, it is like a war. And see, truly speaking, that is permitted. All right, done. So we'll meet at 6 o'clock in the evening, right? Thank you so much. And today I'll definitely say sleep well, right? Okay. Thank you. Bye bye and good night. I'm putting this file into our shared folder.